Hello, my name is Jennifer Brown from Dana-Farber Cancer Institute at Boston. I'm here at CHC, and my topic today will be relapsed CLL. As you know, the field of CLL has undergone some remarkable changes over the last several years, and that's made the therapy of relapsed CLL yet more complex. I like to divide it based on the prior therapy that patients have had primarily. We have a group who've had very minimal therapy, perhaps chlorambucil or rituximab. And that group, as well as people who have had very, very long durations of remission, could still potentially benefit from additional chemoimmunotherapy like FCR. However, the majority of patients with more aggressive disease tend to only have short remission durations with second-line chemoimmunotherapy. And therefore, upon relapse, we tend to favor novel agents, even in first relapse. Currently, ibrutinib has been the standard, with approximately a 52-month progression-free survival for these patients, even with high-risk cytogenetics. New data support the use of venetoclax with rituximab also in these patients, with a 2-year progression-free survival of 85%. So I'll talk a little bit about how one makes that decision between those two options, ibrutinib having more data, longer follow-up, but also more side effects. Venetoclax tends to be better tolerated, and it's a time-limited regimen, so patients like that. But we don't know as well how patients respond after venetoclax if given ibrutinib, and we're still awaiting that data. Then there's the category of patients already exposed to ibrutinib. Now, those who stop for adverse events, as many as 25%, can more or less get any possible therapeutic option, although if they've had a lot of chemoimmunotherapy before or have high-risk disease, then I would avoid that. Patients who progress on ibrutinib, though, represent a new unmet need, and the only data that we have for their therapy is with venetoclax. Venetoclax has a 65% response rate, but complete remission rates and MRD negativity are less in that setting than in the ibrutinib-naive patients, median PFS of about 2 years. Now, when patients progress on venetoclax after ibrutinib, that becomes a true unmet need situation, and so we often consider CAR T-cell or allogeneic transplant for those patients. I'll also discuss some of the novel agents that are coming in the clinic. We have a couple next-generation PI3 kinase inhibitors, 2 classes of next-generation BTK inhibitors, and then combinations are very exciting, particularly the combination of ibrutinib with venetoclax is looking quite interesting in achieving deep remissions and potentially allowing discontinuation of therapy. Thank you.